Greetings everyone. I'm Dr. Gnanapriya, working as assistant professor in radiology department in Lakshminarayan Institute of Medical Sciences, Pondicherry. So in this lecture, I'm going to discuss about the malignant lesions of the liver. So malignant liver neoplasms are classified into primary and secondary. Again, the primary neoplasms are classified by their cell of origin, like if they are arising from the hepatocellular origin or cholangiocellular origin or mesenchymal origin. So those arising from the hepatocellular origin are hepatocellular carcinoma, atypical hepatocellular carcinoma, clear cell carcinoma, giant cell carcinoma, childhood hepatocellular carcinoma, carcinosarcoma, fibrolamellar carcinoma, photoblastoma, and sclerosing hepatic carcinoma. So those that arises from the hepatocellular origin are cholangiocarcinoma and cystadenocarcinomas. From the mesenchymal origin are angiosarcoma, epithelioid endothelioma, epithelioid hemangioendothelium, neomyosarcoma, fibrosarcoma, malignant fibrous histiocytoma, primary lymphoma, and primary osteosarcoma. So the secondary neoplasms includes lymphoma and metastasis. So liver metastasis are the most common hepatic malignancy, with most of the lesions from the primaries is readily seeding to the liver cell. So the most common organs of origin are colon, stomach, pancreas, breast, and lung. So we have a LIRADS, which is the liver imaging reporting and data system. It is a classification system for liver lesions, which is used in patients with liver cirrhosis and chronic HBV without cirrhosis. So because this patient has an increased risk of HCC. This LIRADS will reflect the probability of HCC and is based on the typical CT and MR findings in HCC. So where do you use LIRADS? In patients with cirrhosis or hepatitis B virus infection, or those who have current or higher history of HCC. So we should not use LIRADS in patients who are less than 18 years and the cirrhosis is due to congenital hepatic fibrosis or cirrhosis caused by vascular disorders like Budd-Chiari, total vein occlusion, diffuse nodular regenerative hyperplasia, and cardiac congestion. So we have different categories in LIRADS. The LIRADS 1 is definitely benign lesions. LIRADS 2 are probably benign lesions, and LIRADS 3 are intermediate probability for HCC. Whereas LIRADS 4 are probably HCC, and LIRADS 5 are definitely HCC lesions. Whereas in LIRADS L, 5E lesions are definitely HCC with the tumor present in the vein. Whereas L or M are probably malignant lesions which are not specific for HCC with it. We have 5 major features used for classification in LIRADS, which are the arterial phase hyperenhancement, non-peripheral washout, capsule, size, and threshold growth. So what is arterial phase hyperenhancement? It is a non-rim arterial hyperenhancement of a lesion, which is unequally greater than that of the surrounding river. And non-peripheral washout means a visually accessed decrease in attenuation or intensity from the earlier arterial to the later phases, resulting in portal phase hypoenhancement or delayed phase hypoenhancement. So capsule will appear as a peripheral rim of smooth, uniform border surrounding all or most of the observation. The size of the lesion, a larger lesion has a greater chance of being HCC than a smaller lesion. Threshold growth is increase in the size of 50% or more within 6 months' time during follow-up imaging. A new more than 10 mm mass lesion also represents threshold growth regardless of the time interval. So, if you so in the high-risk patient, if you observe a lesion, in a known case, if it is a treated observation, then you classify as LR treated. So, if a new untreated lesion is there, then you have to classify it into LR1 or LR2, which is definitely benign or probably benign. So the lesions which are classified as LR1 and LR2 are cyst, hemangioma, perfusion alteration, or hepatic fat deposition or sparring, or hypertrophic pseudomas, or a confluent fibrosis or a focal spar. So if those lesions are neither definitely nor probably benign, then we have to use this other 5 features. So the first feature is the arterial phase enhancement. So if the lesion is arterial phase hypo or iso enhancement, or if the lesion shows arterial phase hyper enhancement. So coming to this lesion showing arterial phase iso or hypo enhancement, If the lesion is less than 2 centimeter in size, divide the lesion as less than 2 centimeter size or more than 2 centimeter in size. So the other features, if the lesion less than 2 centimeter lesion, showing the other three features: washout, capsule, or threshold growth. If any one or none of the features are present, then we are classifying these lesions as LR3, which is the intermediate probability. Similarly, for arterial phase hypo or iso-enhancing lesion, which is less than 2 centimeter in size, showing two or more of these features, then we are classifying as LR4 lesions. Similarly, for a arterial phase iso and hypoenhancing lesion, which is more than 2 centimeter in size, showing none of these features, then they are classified as LR3. Showing one or more of these features, then they are classified as LR4. Next, coming to the arterial phase hyperenhancing lesions, by size wise they are categorized less than 1 centimeter or 1 to 2 or more than 2 centimeters. For less than 2 centimeter lesions without any of these three features, they are put into LR3 categories. So for a less than 1 centimeter lesion, even with one or more of these features, they are classified as LR4. For between 1 to 2 centimeter lesion with one of these features, we have classified as whether it can be LR4 or LR5, depending upon the presence of ancillary features that may favor benignity or malignancy. So that I will discuss in later slides. So for the same size lesion, if two or more features is present, then they are categorized as LR5. Similarly, for more than 2 centimeter lesion showing arterial phase hyperenhancement, if none of the features is present, then they are LR4. If one or more of these features is present, then they are LR5. So, what are these ancillary features? So, the ancillary features that may favor HCC or some features may favor the benignity. So those features that will favor HCC may be applied to upgrade the category to one or more categories, but not beyond LR4. We cannot use to upgrade to LR5. So also, absence of this feature should not be used to downgrade the LR categories. Similarly, ancillary features that may favor benignity may be applied to downgrade the category by one or more categories. Absence of this feature should not be used to upgrade this LR category. So what are those features that favor HCC? These are the mild to moderate T2 hyperintensity, restricted diffusion, corona enhancement, mosaic architecture, nodular architecture, intralesional fat, lesional ion sparing, lesional fat sparing, blood products, and a diameter increase less than that of the threshold growth. So these features will favor the HCC. If these features are present, then we can use to upgrade the grading to up to LR4. So features that may favor benignity are marked homogeneous T2 hyperintensity, homogeneous marked T2 or T2 gradient hypointensity or undistorted vessels. This vessels parallel blood flow enhancement or a diameter reduction in the size of the lesion or a diameter being stable for more than 2 years. These features are favor the benignity. Presence of these features may be used to downgrade the LR category. So coming to the individual lesion per se, the first lesion being hepatocellular carcinoma. This is the most common primary hepatic tumor and it is one of the most common visceral malignant neoplasms. So etiology varies among different population groups, but the most common risk factors include hepatitis B and C infection, alcoholic cirrhosis, hemochromatosis, and exposure to carcinogens like alpha toxin. So the gross appearance, the lesion may appear solitary, multifocal, or diffuse. Solitary lesions are usually large bulk mass in one lobe. Multifocal lesions present as multiple independent nodules. Diffuse appearance will show us innumerable nodules in varying centimeters. HCC is being a soft tumor that frequently undergoes necrosis and hemorrhage because they don't have stroma. So vascular invasion of perihepatic vessel is common here. By morphological classification, the lesion less than 2 centimeter classified as small HCC, whereas more than 2 centimeter are classified as large HCC. Coming to the hepatocarcinogenesis, so in a cirrhotic liver, there will be a regeneration of the hepatocytes occur. So this regeneration will appear as hepatic, micro, and macronodular appearance. So on this nodules, they undergo dysplasia, which is less than initially as a small foci, less than 1 mm, known as dysplastic nodules. Then this dysplastic nodule becomes larger in size, more than 1 mm. Then we classify it as low-grade dysplastic nodules. This low-grade dysplasia, there occurs a high-grade dysplasia. So we classify it as high-grade dysplastic nodules. Within the dysplastic nodule, there occurs a focus of HCC. Then it is called as dysplastic nodule with focus of HCC, also known as nodule within a nodule appearance. Then this nodule will turn into a larger HCC. So this is the image representation of the hepatocarcinogenesis. So there occurs first regenerative nodules occurs in the cirrhotic liver. So within this regenerative liver, there is a foci of dysplasia. So this foci of dysplasia will become bigger in size with a moderate to high moderate ATP occurs. Within this dysplastic nodule, there occurs a foci of hepatocellular carcinoma. Then this hepatocellular carcinoma will grow in size, giving nodule appearance. Then it largely grows into a moderately or poorly differentiated HCC or a larger HCC, which is more than 2 centimeter in size. So coming to the ultrasound appearance, it has varying appearance in ultrasound. So in a background, you can say as the background of cirrhotic liver, there can be a heteroechoic nodule with a cystic spaces or a solitary hyperechoic nodule or a large irregular heteroechoic lesions. So it has a varying appearance. You can also see a tumor thrombus within the veins. So the solid tumors without necrosis are usually hypoechoic areas, whereas hyperechoic appearance is usually attributable to fatty metamorphosis, fibrosis, or sinusoidal dilatation. The majority of HCCs which are usually less than 2 centimeter, are hypoechoic, whether larger HCCs are hyperechoic or of heterogeneous echotexture. Color Doppler also demonstrates international vascularity, as it is a vascular lesion in the form of tangle of vessels within the tumor, or even arteriovenous shunting may be seen. So HCC has a propensity to invade the vein, hepatic veins or both, and this is depicted as echoes, which are either partially or completely filling the lumen. So to differentiate this from the non-tumor thrombus, we have to use color flow Doppler imaging. So the presence of arterial waveform within the thrombus indicates it is neoplastic rather than a blunt thrombus. This distinction is vital because it has shown that presence of malignant portal vein thrombosis is the worst prognostic factor in predicting recurrence of HCC, either following surgical resection or liver transplantation. So coming to the CT appearance, so if there is a multiple nodule in a cirrhotic background showing early arterial phase enhancement, and the lesion shows washout in the later phases. So similarly, this is a solitary arterial phase enhancing lesion which is showing washout in the delayed phases. There is also a arterial phase enhancing solitary lesions which is more than 2 centimeter and showing washout in delayed phases with a capsular enhancement. So, the multi-detector CT, the protocol includes So multi-detector CT, the protocol includes first a plain or non-enhanced CT, then a hepatic arterial, portal venous, and delayed phase images. It's an efficient technique. And also it is used for preoperative staging of HCCs. So in a plain CT, this HCC will demonstrate is a large hypodense mass with areas of low attenuation that correspond to the tumor necrosis. So normally, HCC derives most of its blood supply from the hepatic artery. So the tumor shows earlier enhancement during the arterial phase, and it is relatively hypodense on the delayed phases due to the early washout of contrast medium by the arterial blood. So the tumor has a variable appearance on the portal phase images. If the small tumors may appear as lesions of different attenuation, whereas the large ones almost always demonstrate central necrosis. The capsule appears iso to hypodense related to the normal liver during the hepatic arterial phase, and it enhances on the delayed CT images. So here again, in a background of cirrhotic liver, there is a small arterial phase enhancing HCC protruding from the surface of the liver. So in the follow-up scans after 3 months, the lesion shows a rupture, and there is a hematoma, crescent-shaped hematoma over the liver. So this is sign is known as enucleation sign where the HCC is ruptured. Coming to the MRI features, so the MRI also shows the same pattern of enhancement as seen in the CT. So it is a slightly hyper intense nodules in the liver, which shows arterial phase enhancement. So and washout with the capsular enhancement in the delayed phases. So similarly, here is a large SCC lesion showing irregular arterial phase enhancement and washout in the delayed phases with a thin capsular enhancement. So there can be different types of nodules with varying appearance in the liver showing MRA. So the types of nodules can be a regenerative nodule or a well-differentiated dysplastic nodule or a poorly differentiated dysplastic nodule or a well-differentiated HCC or a poorly differentiated HCC. So this nodules can be differentiated by their appearance in MRI. So these regenerative nodules will appear iso to hyperintense in T1, whereas iso to hypo in T2. And this lesion shows iso to hyperenhancement in the portal venous phase or delayed phases because they can enhance in these phases. Whereas well-differentiated dysplastic nodules, they usually variable in appearance in T1, usually hyperintense in T1, whereas hypo to iso in T2, and similarly it enhances in the portal venous and delayed phase imaging. Whereas a poorly differentiated dysplastic nodule has a variable T1 appearance, which appears mildly hyperintense in T2, and it enhances in the arterial phase, but it will not enhance in the delayed phases. But there is no washout in this delayed phases. Whereas a well-differentiated HCC has a variable T1 appearance and it appears hyperintense in T2 and it enhances in arterial phase without and shows washout in total venous phase, but delayed phases it may or may not enhance. Whereas a poorly or moderately differentiated HCC shows heterogeneous appearance in T1, hyperintense in T2, and it enhances in arterial phase, showing washout in total venous phase with no enhancement in the delayed phases. So with this, we can classify the types of nodules in the cirrhotic liver. So angiography, so since it is a hypervascular lesion, so most ACC appears hypervascular with marked neovascularity and arteriovenous shunting. There may be areas of avascular or hypovascular areas because of the result of hemorrhage and necrosis. There can be extension of the tumor into the porta hepatis and other perihepatic veins. So the presence of threads and sticks sign is a characteristic of intravenous tumor thrombus. Coming to the other variant, which is the fibrolamellar variant or fibrolamellar carcinoma, it is a slow-growing tumor that arises from the normal liver, so not in a cirrhotic liver. It is composed of neoplastic hepatocytes separated into parts by lamellar fibrous stands. So grossly, it usually arises in a normal liver with only 20% of patients having underlying cirrhosis. So FLC usually occurs in adolescent and adults who are younger than 40 years of age without underlying cirrhosis or other predisposing risk factors. So ultrasound, it will appear as a large heterogeneous lesions. In CT, you have a well-defined hypodense lesion which shows heterogeneous enhancement, but there is a non-enhancing central scar, hypodense scar in the lesion. So on an unenhanced or plain CT, these lesions will appear as hypodense mass with a well-defined contour. So areas of hypodensity or decreased density within the tumor corresponds to the central scar or necrosis or hemorrhage. Stellate calcification within the central scar can also occur. During the arterial and portal phase, the non-scar portion shows heterogeneous enhancement. This heterogeneous enhancement present during the arterial and portal phases corresponds to the more vascular and cellular portions of the tumor in comparison to the fibrous and necrotic portion, which usually do not enhance. So this is the MRI appearance showing a well-defined large lesion with a central hypointense scar. So FLC is usually hypointense or isointense with the normal liver parenchyma and T1, which are iso to hyperintense and T2 images. Because of this, the purely fibrous nature of the scar will appear hypointense on both the T1 and T2 images. So the major differential for this fibrolamellar carcinoma is the FNH, which is the fibronodular hyperplasia. How to differentiate between these two? The scar in FNH is hyperintense in T2 weighted images, and it shows a high signal intensity on GR images. whereas the scar is hypointense on T2 weighted images in fibrolamellar carcinoma, and there is no signal from GR images. Whereas there is no calcification in the focal nodal hyperplasia. The calcifications are frequent in fibrolamellar carcinomas. And the FNHS usually has no symptoms. They usually seen as an incidental findings, whereas fibrolamellar carcinoma patients are usually symptomatic. When you biopsy these lesions, you find only normal hepatocytes, portal branches, and biliary ductules, whereas here you see the malignant eosinophilic hepatocytes, no portal branches or no biliary ductules. Coming to the other neoplasm, which is the hepatoblastoma, it is a malignant tumor of hepatocyte origin. It is the most common primary liver tumor of the childhood. It usually occurs in the first 3 years of life. Serum AFE levels are frequently elevated. Pathologically, it tends to be well-defined, pseudo-encapsulated, large, and unifocal lesions. Less commonly, occur as multiple nodules or diffuse liver involvement can also be seen. Calcification is also seen in up to 1/3 of the patients. So here is a large heteroechoic lesion with cystic areas and the calcifications are seen in the liver. Here again showing the CT of hepatoblastomas, a large hypodense lesion showing variable hypoenhancement in the liver. So hepatoblastoma in MRI, it is usually hyperintense on T2 and hypointense on T1 weighted images. There can be a focal of high signal on T1 weighted images due to hemorrhage. Similarly, there can be on T2 weighted images, this septations can occur, which can appear as a hypointense bands. The mixed type of hepatoblastoma may demonstrate more heterogeneous appearance on both T1 and T2 images due to necrosis, hemorrhage, fibrosis, calcification, and cartilage and septal components. Coming to the other cell of origin tumor, which is the intrahepatic cholangiocarcinoma, which occurs from the cholangial cells. So it is a biliary duct origin. It originates in the small hepatic ducts and tends to have poor prognosis with a high morbidity. It occurs only for 10% of all cholangiocarcinomas. It has an increased incidence in patients with Crohn's disease, sclerosing cholangitis, intrahepatic calculi, and inflammatory bowel disease. So the ultrasound appearance vary according to the type of pattern of growth. It can be either mass-forming intrahepatic lesion or a periductal infiltrating intrahepatic lesion or an intraductal lesion. So mass-forming intrahepatic will show as a variable echogenic well-defined or ill-defined lesion in a liver, whereas periductal infiltrating is difficult to identify. Other than that, we will have a ductal dilatation or the biliary duct dilatation. So similarly, intraductal lesions or biliary dilatation with the mass within the ducts. So CT here again showing a hypodense lesion, irregular hypodense lesion, the mass forming type, which shows a delayed enhancement. Same MRI showing a hypointense lesion, which is showing a delayed phase enhancements. With the dilatation of the biliary ducts also seen. So MR imaging does not show any characteristic features, and the lesions are usually hypointense on T1 and hyperintense on T2. For a smaller lesions, which are 2 to 4 cm, they enhance homogeneously, but more than 4 cm lesions shows a thick peripheral enhancement with the centripetal progressions. However, the presence of satellite nodules, portal vein invasion, and dilated bile duct favor a diagnosis of intrahepatic cholangiocarcinoma than the hemangioma. Also, in diffusion weighted images, they show diffusion restriction unlike hemangioma. So, next, moving on to epithelial hemangioendothelioma. It is a rare malignant hepatic neoplasm of vascular origin that develops in the adults. Pathologically, the multiple tumors are usually present that tend to grow and coalesce to form a confluent masses. This lesion usually develops in the periphery of the liver and commonly shows calcifications corresponding to the fibrotic nature of the tumor. So in ultrasound, they are seen as hepatic lesions that are predominantly hypoechoic. However, hepatic lesions can also have mixed echogenicity or can be hyperechoic also. In CT, they are seen as multiple hypotentrating lesions in both the lobes of the liver, and they coalesce to form larger confluent hypoedetic regions in a peripheral or subcapsular distribution, and a halo or a target pattern of enhancement is seen in larger lesions. Subscapular lesion often present with capsular retraction. So MRI and T1 weighted images, they are usually hypointense lesions, and T2 weighted images, they show heterogeneous increased signal intensity. Coming to the next, angiosarcoma, it is the most common primary sarcoma in the liver. Although it is a rare liver tumor, it commonly affects patients of 60 to 70 years of age, but also it can occur in younger patients. These lesions have predominantly male predominance with a ratio of a male to female ratio of 4:1. So, this angiosarcoma is a malignant tumor derived from the endothelial lining cells. It occurs primarily in adults with exposure to a variety of chemical agents and radiations. So, previous exposure to toxins such as thorotrust, vinyl fluoride, arsenics, and steroids can it can also occur in patient with the hemochromatosis. So angiosarcoma again shows a heteroechoic lesion, which is a fairly defined heteroechoic lesion in ultrasound. The CT features, it is a irregular hypodense lesions which will show irregular peripheral enhancement. The one feature of enhancement that favors angiosarcoma is the flame-shaped irregular progressive enhancement, but the enhancement is never complete. Coming to the lymphoma of the liver, so hepatic lymphoma can either be primary or secondary, and can occur both in the Hodgkin's and the non-Hodgkin's lymphomas. So the majority of lymphomas are usually secondary and found in more than 50% of the patients with either Hodgkin or non-Hodgkin lymphomas. Primary is rare. So early in the disease, liver involvement is only microscopic, but with time, the small nodules form a few millimeters to several centimeter in size. Later on, they develop into a several centimeter size. So Hodgkin lymphoma of liver is invariably associated with the splenic involvement, and the likelihood of hepatic disease is greater if there is an extensive splenic disease. So lymphoma appearance, again, it also varies. It can present as multiple hypodense nodules, multiple hypoechoic nodules in the liver. So CT features also shows hypodense, hypoenhancing lesions with multiple hypoenhancing lymph nodes. Coming to the metastasis. So metastasis are four by the most common malignant focal liver lesions. It is outnumbering the primary malignant tumors by a factor of 18:1. Because the liver is the second to the regional lymph nodes as a site of metastatic disease. Approximately 25 to 50% of all patients who die of cancer have liver metastasis at autopsy. So the common primary neoplasms that metastasize to liver are the colon, stomach, pancreas, breast, and lung. So the highest percentage of liver metastasis occurs in primary carcinoma of the gallbladder, pancreas, colon, breast, and the lowest occurs in the prostatic cancer. So ultrasound has a diagnostic sensitivity of 90% in detection of metastasis. The sonographic appearance of liver disease may be echogenic or hypoechoic, target appearance or calcified appearance, or a cystic or a diffuse metastasis. So echogenic or a hyperechoic metastasis usually arise from the gastrointestinal cell of origin or from the seed cell. So the more vascular the tumor is, the more likely that lesion is going to be echogenic. Therefore, mets from RCC or neuroendocrine tumors, carcinoma or choriocarcinoma or islet cell carcinoma, which are all hypervascular tumors. These lesions that also tend to have hyperechoic metastasis. In this particular group of tumors, they may also mimic hemangioma sonography. So hypoechoic metastases are usually hypovascular. They can be mono or hypercellular without any stroma. So hypoechoic lesions represent the typical pattern seen in untreated metastatic breast or lung cancer, as well as in gastric, pancreatic, or esophageal tumors. Lymphoma involvement are also present as hypoechoic masses. The bullseye target pattern is characterized by a peripheral hypoechoic zone like this. This appearance is usually non-specific, but it is more common and it is frequently identified in mets from bronchogenic carcinomas. Next is the calcified metastasis. They are distinctive. because this calcium can appear either as a large echogenic lesion with a posterior shadowing, or it can be multiple innumerable tiny punctate calcifications which do not show any shadowing. So this calcific metastasis is frequently associated with the mucinous adenocarcinoma of the colon. Coming to the cystic metastasis, they are usually uncommon but generally exhibit features. You have to distinguish from this benign hepatic cysts, which are neural nodules, thick walls, fluid levels, and internal septations. The primary neoplasm with a cystic component like cystadenocarcinoma of ovary, pancreas, mucinous carcinoma of the colon, they may produce a cystic secondary lesions to the liver, although it occurs very infrequently. More often, cystic neoplasm results from extensive necrosis, seen most often metastatic sarcomas, which typically have low echoes and a thick and shaggy wall. So again, metastatic neuroendocrine or carcinoma tumors are typically highly echogenic, and may also show secondary cystic change. Large colorectal metastasis may also be necrotic, producing a predominantly cystic liver mass. So these are the varying appearance of the cystic metastatic lesions with a thick wall and the neural nodules. So in CT, the metastasis can be hyperdense, iso or hypodense, or it may show hypodense lesion with the peripheral enhancement. That can be a cystic complex or a calcified lesions can be there, or it can be a complex appearing, or even it can be a diffusely infiltrating lesions. So the CT appearance again depends on the tumor size and vascularity and the degree of hemorrhage and necrosis. Thus, individual metastatic lesions within the liver can have different CT findings, and metastasis from different cell types can appear identical. So most of the major metastases are hypodense with attenuation between that of water and normal liver. So these lesions are usually hypovascular, and on contrast, increases their conspicuity by increasing the density of the normal liver. So these lesions can be easily identified during the portovenous phase. They will appear as hypoenhanced lesion in the portovenous phase. So usually the colon, lung, prostate, gastric, and bladder cell transitional carcinoma is the most common tumors that appear as hypovascular liver metastasis. This is the lesion showing hypodense lesion, which is become more conspicuous in the portal venous phase. Irregular, multiple hypoenhancing hypodense lesions in the liver, favoring metastasis. Again, hyperdense metastases are uncommon. These lesions are hypervascular and they enhance rapidly and diffusely, becoming isodense with the normal liver. These lesions may be difficult to visualize on contrast and CT scans. So these hypervascular metastases are usually occurs from the primaries are usually the melanoma, carcinoid, pancreatic islet cell tumor, choriocarcinoma, leukocytoma, breast cancer, thyroid carcinoma, and renal cell carcinomas. Ring enhancement of a hypodense mets occurs, which represents usually a vascularized viable tumor which is present in the periphery, contrast with a hypovascular and a necrotic center. So it is a peripherally enhancing hypodense tumor. So the MRI features of metastasis are, it again varies because the T1 and T2 relaxation times of liver metastasis, they vary considerably. It depends upon the primary tumor, degree of necrosis, hemorrhage, and vascularity. In spite of that, the T1 and T2 relaxation types of most metastases are longer than those of the normal liver and shorter than that of the simple cyst or hemangiomas. So we have 6 major morphological patterns that has been described on for metastasis and MR images. The one is the donut sign. So the donut sign is on the T1 weighted images. This metastasis, because of their long T1 relaxation time, they present as a low signal intensity mass, again containing a distinct central region of even lower signal intensity, giving the appearance of a donut sign. This pattern is usually seen with larger lesions and those that are prone to undergo necrosis. So next is the target appearance. This target appearance is seen in T2 weighted images where some mets present with a central smooth or irregularly rounded area of high signal intensity, which is surrounded by a rind of tissue with somewhat weaker signals appearing as a hypointense than the central hyperintense signal, giving rise to target appearance. Next is the amorphous pattern. This metastasis, they have a variable increased signal intensity with inhomogeneous and featureless content. So the outer margins tend to be round and indistinct. Other type is the halo pattern. Here the masses have a distinct but not necessarily smooth circumferential ring of high signal intensity. The ring thickness varies from 2 to 10 mm and it encircles a lesion of somewhat lower signal intensity. This halo is probably a manifestation of greater water content than in the adjacent normal parenchyma, whereas reflecting a edematous reaction incited by the tumor cell infiltration. The other pattern is the light bulb pattern. Here the lesions are smooth, sharply defined, round or can be elliptical. So these contents have a high signal intensity that may be due to complete tumor necrosis or liquefaction or a hypervascular mass giving to the light bulb appearance. Thank you.